Urine drug toxicology once again. We're going to talk about our usual factors, and one of the things I want to focus on this time, and maybe even encourage discussion if that's okay with our moderator today, is talk about clinic policy formation. And we've been doing urine drug toxicology for about 4 years now as a community. We're testing people, we're better at it. We get these test results, but it still is a conundrum of what exactly we want to do with the results. And the results I'm talking about are the aberrant results that we see. There's a significant literature that tells us that this population is going to have aberrant results. So I think we need to think a little bit about what we do with these results and not just jettison the patient to our colleagues in the community. We're going to talk about the collecting and ordering processes. Again, review the types of UDT. I've spent a fair amount of time talking to our toxicologist recently. We are not doing a lot of other tissues currently. One issue is funding and changing the labs around. So I'm going to just continue to talk about urine, which is probably the gold standard. We ultimately will, as a field, be doing other things, but I'm not going to talk about that technology today. We're going to talk about the science and a little bit about technology of urine drug testing. We're going to talk about result interpretation, communication with our lab, a little bit about frequently asked questions, and then talk about what may be coming down the line in future in terms of future documentation. We all know why we're here. We're here because of the patients not always being forthright with us. We're here because of the incidence of illicit and controlled substance abuse in our patients. We're here because of the death data, and we're here because we're now using this technology, and we need to figure out as a provider community how to use it. So why do we bother? And I think that as we need to document more, it's worthwhile asking these questions because we need to document why we're doing it. We want medication adherence to help with patients getting in line for doing what they really should do. It also can be a diagnostic tool. It helps us with the initial diagnosis of drug misuse or addiction. It's an adjunct to self-report, and it's not a replacement, but it is an adjunct, and we should still be talking to our patients. We want to reinforce behavioral change, and it's a requirement of ongoing treatment in virtually every clinic that prescribes opioids and for all the national organizations. And a potential offshoot is, as providers, and we do like our lab tests, there is now a test, and we have data that we can put into our notes. When you're formulating your policy, figure out why you're using UDT in your clinic. There will be additional impact of the Center for Medicaid and Medicare guidelines. What are you going to do with the results? You're going to educate your patient. You may adjust the dose. You may stop the opioids, but get a sense of what you're going to do with the results as you're making your policy. Which gets down to why are we doing it anyway? What are our goals for monitoring patients for opioids? We're worried about safety, and we're hoping that the opioids are going to improve functioning in our patients. The types of testing, the point of care, the office test, which is really great. We can get results right away. There's a laboratory immunoassay, which is a better immunoassay. It has lower cutoffs. And the confirmatory test, which either is gas chromatography or liquid chromatography. The point of care is only a screening test. It's office-based. It's immunoassay with high test results, and there are many positives and false negatives, and there's some drugs that aren't going to appear on any results. That is the benzodiazepines and fentanyl. And remember our little friend that I have on our next slide, CLIA waived. So what is CLIA waived? CLIA is the Clinical Laboratory Improvement Act. It allows us to do laboratory tests in an environment that is not a lab. So it does not have the requirements that most labs do. The requirement is that you teach your staff, which takes about 45 minutes, and that you have a place to do it, that you're consistent in what you do, and you recognize that this test is a preliminary test. Just as a gynecology doctor is not going to do a termination of a pregnancy, if that's what they want to do, based on a very simple pregnancy test, we shouldn't be stopping opioids just on the base of a of a point of care test. So it's a screening test. What's expected? It's a screening test. It measures drug classes with high cutoffs. It needs to be confirmed. That's part of the CLIA waived factor. If it tells you where you want, you may stop there. And a lot of people, for cost considerations, do stop there. Because at our institution, a full panel that we run, and in our clinic we do confirmatory testing because of our patient population, can run in the $700-800 range if you don't have insurance. Some insurances don't want to pay for them very frequently, and some insurances don't want to pay for them at all. But it doesn't provide our point of care on clarification on amphetamines versus methamphetamines, specific benzodiazepines, or fentanyl. So you may need to do a more specific test depending on what substances you're looking for. The laboratory immunoassay works on the principle of competitive binding. Structurally like compounds will attach to the receptor site and they may interfere. It mostly measures metabolites. It doesn't measure the drug, and the results are read as positive or negative. So besides forming a policy, which I said a few minutes ago, the next most important thing is when you look at the results, if it's positive or negative, it's an immunoassay test. So take that away because I think that's important. There are 6 different tests. Some are better than others. Different labs will decide what to do, and it has lower cutoffs, so it's a better test than the point of care testing. Confirmatory testing is gas chromatography or liquid chromatography mass spectroscopy. Lower cutoffs. It may be more appropriate in chronic pain management because we want to know whether the patient is taking oxycodone or hydrocodone. We don't just want to know it's an opiate. We want to know which drugs. And the test result is read in numbers. The numbers do not reflect dose. I wish it were the case, but that is not an issue at all because of the variation in metabolism and the different factors of metabolism. And billing is often based on each drug you ask for. Sometimes they're lumped. Make sure you know from your lab how they're lumped together in terms of cost. Here's the science part of the lecture. Mass spectroscopy offers the chromatographic separation and mass fragmentation of the patterns that are characteristic for each medication. So you're getting the drug. You're able to identify the drug with this. The isotopic dilution is the quantitative part, and it's considered the gold standard. However, the quantitative excretion does not relate to the medication dose overall. It may relate more to what time the patient took the drug relative to the sample being taken, but that's about all we can say. There are too many metabolic factors to be able to go further. Sample validity. If you're concerned of adulteration and if your MA says, well, this kind of looks funny, look at color, temperature, excessive bubbling. But in the future, that's going to be our responsibility as providers. Payers are not going to reimburse for confirmation of specimen validity, and that was really fairly straightforward and repetitive in the early CMS guidelines that still have not formally come out. So for temperature, you want it between 32 and 38 degrees centigrade, and specific gravity within these particular numbers. So if you wish to do office testing, monitor the patient's behavior if you're concerned about that. There are all sorts of devices that can give you a false urine. They're on the web. You can look at them. If you have such patients or really have concerns, this may not be the best patient for you to be treating in your office practice. So what do? You get your urine, and then you ask the patient, when did they take their medications? If you've given them 60 oxycodone tablets, it's week 3, and they've used them all up, you may not need to go to the trouble or the cost of doing the urine drug test. There is a conversation there, but you may not need to do your test. Ask the patient if there's any unexpected substances. Tell the patient that this is all about safety. This is why we're doing this. And don't forget our friend, the PMP, which I think we had a lecture about last week. So now we've ordered the test, and now the interpretation and what do we do with this? And this is pretty complicated. I encourage you, if you haven't memorized this already, to print it out and have it available. It goes along with this next slide, which has gotten fuzzier, and I think my red mark has moved a little bit. What I want you to know is that hydromorphone is at the center of morphine, codeine, and hydrocodone, but oxycodone is a completely different substance. So if your patient, hydromorphone will appear on the results a lot. Just make sure that you know what the parent drug was and where it goes back to. But you'll see a lot of hydromorphone. Cocaine has a high specificity. It doesn't really react with anything. It's a local anesthetic type medication. So it's very specific, and that's why we still use a very, what our toxicologists feel to be a very good immunoassay test. However, amphetamines look like lots of different things, and so you need additional testing to differentiate between your ADHD drugs and whether the patient is partying and using methamphetamine. So toxicologists, it was wonderful about 3 years ago when we were able to convince our toxicologists to have written comments accompanying the results. The information I just presented to you is available to you in case your toxicologists don't. If you're not sure what the results mean and you have too many drugs and you're not sure that come back on your confirmatory testing, call your toxicologist. Because if you call them a few times, pretty soon you won't need to, you'll understand. It also provides backup for your action if you've decided that this patient shouldn't be on medications, and you can say, look, I talked to my toxicologist, it was really there, and I think we need to act on these results. Why would you have a negative test? The patient not recently using the medication. They may excrete or metabolize the medication at a different rate than normal, and there's some drugs that can have an effect on that, especially rifampin. The test was not sufficiently sensitive to detect the medication. That's the case for fentanyl. That may be, and here I'm getting at immunoassay versus confirmatory testing. And always, we need to keep in the back of our mind, this is a laboratory test. Tests can go awry, and is there a clinical or technical error? I think most of the time we just assume the test results are right, but we need to think about this in the back of our mind. Patient didn't use the medication, and here's something that we need to think about, and that is what is on the SIG. I see repeatedly it's 1 to 2 POQ, 4 to 6 hours PRN, and those are the safety numbers. But if you give somebody 60 tablets and you only want to refill it in a month, you should tell them it should also say max 2 tablets a day, or better, it should say no more than 4 hours apart, or no closer than 4 hours apart, and no more than 2 tablets a day. Put what you mean. And there may not be, for some substances, a good metabolic test yet available. Laboratory area, it's one of these tests are part of our process for adherence drug monitoring. It is different than those for the impaired physician. It's different than people in the military, and that is, it is not witnessed. So it's subject to some of the potential errors as in all laboratory testing. And although this isn't really what we expect, I've seen in a number of chart notes and heard from physicians that things got haywire at a particular day in their clinic. So just make sure your process is running as smoothly as possible, because there can be laboratory error. So you've done a test, and you've gotten your results, and now you have to meet and decide what you're going to do and what you're going to tell a patient. So you go back to your policy. What does your policy say? Who are you doing testing on? How are you doing testing? I think we all need to think about marijuana, and are you going to allow your patients to be on it? Are you going to test for it? It is legal. It can be used recreationally. And what actions are you going to take on those results? Now, I think we have people from other states besides Washington. Sorry about that. This is a lecture that I'm used to having people only in Washington. So it may not be the case that it's legal in your state. You should include urine drug testing in your patient care agreement. And you should also include in your patient care agreement that you may do callback UDTs. And if there's someone you're just not sure about, and most patients expect to be urine drug tested when they come in to the clinic. I see a patient maybe, if there's a patient I see maybe every 6 months, primarily as a consult, not that I'm prescribing. And they want to give a urine sample when they come in. They expect to. If you're really monitoring someone, you may need to call them back, give them 24 hours, and just see what you see. So what is the literature? The literature is disappointing. There is one good VA study that we'll refer to, but we don't yet, and I've been giving a similar lecture for about 3 years now, we don't really know what to do with the results, and the literature isn't helpful as of yet. So what do you do with the test results? In terms of the gaps, we don't know how to diagnose diversion. It's really something that you have to have an index of suspicion, or your comfort level is just too high. We don't know who should be given a second chance, although there's one study we'll talk about in a minute that shows that cocaine users are probably at highest risk. Which diagnosis is appropriate to use in opioid therapy for, and how do we approach marijuana with its popularity for both medical management, and now it's becoming increasingly legal for recreational use. So how do I approach this? I think we should review our data. We should look at all the data we have on the patient, and that includes starting with the UDT. Is it compliant? Do you see what you want? Do you not see what you don't want? So is it compliant? Is it not compliant? We'll start with our test. And then what are the risk factors? So what other data do we have? We know about risk, and we know that risk increases as the dose goes up. There can be comorbidities that increase the risk, such as liver failure, such as kidney failure, such as heart failure, depending on what drug you're using. Obstructive sleep apnea is a risk, and addiction history is a risk. What about aberrant behavior? Early refills, lost script. All this is data that we can collect, and we have in our chart in the patient. So what are the actions? You can continue the prescribing plan, and that's absolutely reasonable. But if you have an aberrancy that is related to a lab test, put your thinking in the chart. Don't just do one of the things I'm seeing a lot of, and that is people click on a template and they say aberrant behavior, discharge from clinic, and down at the bottom it has all this verbiage about how the patient is participating in care and needs the opioids. Make sure it all fits. But document, if you're going to maintain it and the patient's had an aberrancy, document why you're going to continue the plan. That's a possibility. More frequent refills, I really love this. Weekly or every other week. Every other week you can probably get by with some insurances. Weekly the patient has to pay. But if you're concerned about safety because the patient's on high dose, that may be the safest way to deal with caring for this patient. You could lower the dose, a structured second chance, stop the opioids, and don't forget that your additional consultations, because you may be unearthing other diagnoses, that is mental health or addiction medicine consultations. There are no real studies, but the literature doesn't support ongoing opioids with greater than 4 aberrancies because we've seen it's those patients that come up with illicit substances. And in a VA group out of Philadelphia, they found, and this was in a clinic where all the patients with aberrancies went, that patients with illicit present and a history of substance abuse of cocaine were more likely to have ongoing aberrancies and weren't able to be brought into the fold, as it were. So cocaine's a bad actor, it appears. So what's the diagnosis? First of all, has the patient adequately been worked up, or are you the second person to be assuming care, or the fourth or the fifth? Make sure you know what it is that you're treating. Is the patient participating? Because monotherapy has long since failed, and is the patient as functional as possible for whatever structural lesions, such as Dr. Robinson's patient lesion. Often these patients have pain. I'm not saying they don't have structural lesions, but they need to participate in their care. So what do we do about marijuana? There are no documented overdoses of marijuana only. There are no data on the negative positive effects combined with opioids. There's a good review that in the British literature that suggests some benefit in neuropathic pain. Unfortunately, the substance that they use is different than we use in our country. So it's difficult to generalize. But there are people out there that are working on the marijuana issue and gathering more data so we can understand who it might help. Marijuana is a sedative, and some, if you use the THC component, and We don't really know about the combination with alcohol, although I do understand from going to meetings there are several groups that are looking at the safety of marijuana and alcohol. Whatever your choice of action, especially if it's slightly out of the box, document what you're going to do and explain what you're going to do, and jettison your template when you talk about action, unless it's really mainstream, because having aberrant behavior and then seeing all this template verbiage really doesn't fit. So we know that there were some lawsuits about too much drug testing. I think we have a reason to do it, but this is part of the documentation. Document what you need to do. The quandary about this, about the lawsuits, is what to do with the results. We know there's a lot of this testing, but it's a test. And the other part of the quandary is, are the results accurate, and when might will the result from the lab be wrong, or some of the process be wrong, and we don't really know. So what are the pitfalls? It won't be useful if the medications are taken very PRN, which unfortunately for me, my current most common recommendation is low dose PRN, not every day. You can't use a UDT to test for that. It's very hard to diagnose diversion. There's no test, and I think we look at the hallmark of prescribed drug absent, illicit present, but there's really no proof there. And again, UDT is one data point, not everything. So what do I get asked a lot? How come these numbers can't be used in some ways? Specifically, item number 2, can patients be their own controls? And our toxicologists and the metabolic gurus say no, because there are too many factors, such as when was the testing relative to what the patient ate, when they last took their medication. We just can't put it together. It doesn't fit in the double-blind, placebo-controlled model that we want to have where we control all the variables. There are just too many variables. And what do you do about marijuana? We had hoped at some point, the last time I gave this talk, that our Attorney General was going to give us some guidance, but we don't have enough data to have them be able to say anything specifically. So we don't really know about the use of marijuana and the other sedatives. It's up to us as the practitioners, the pain people, to try to come up with something that's helpful, and we don't have that. And we have, Dr. Robinson gave a good talk on marijuana, which described that we really need more data, and people are working on that. But the evidence is really inconclusive, especially with respect to what it means in terms of safety as well as who benefits. So CMS is going to formulate new guidelines about urine drug testing, and I think the best thing I want to say is they're concerned about cost, as the government often is, and insurance companies are. Document why you're doing the urine drug testing, and if you're going to do confirmatory testing, you want to think through why you need it and put that down in your chart note. And here are some sample statements. You're ordering immunoassay to detect for this, the absence of that, and you'll do confirmatory testing when prescribed medications are not present for screening. And another possibility is screening for illicit substances is ordered due to certain patient history, patient taking their mother's medications because their medications have been stolen, whatever. But write down why you're doing it. And I think that you're going to be paid, it'll be paid for under the new guidelines that come out. So CMS will probably deny confirmatory testing if you do it without a reason. So if you have negative immunoassay results, unless you have a reason, in the future they may not want to pay for the other tests. So tell them while you're doing it, because there's usually a rationale. It shouldn't be a reflex tick on the box. So in conclusion, there's different types of tests. The most sophisticated is easiest to interpret. It gives you numbers. It's the most reliable and the most expensive. You need to decide what action is generated by the test results, and that gets back to policy formation. So does every patient, and the question I want to put to you, need to have their opioids discontinued for an aberrancy, and are there different layers of aberrancies? CMS guidelines are going to require more documentation and more specific documentation. And remember, this is just one tool.
Okay, well, thank you, Susie.